Welcome everyone to the SAEM lecture series. My name is Rush Dillon. I am the Pediatric Ultrasound Director at UMC South Alabama, and today we'll be discussing the appendix ultrasound. Let's go through some learning objectives, understanding the importance of ultrasound in appendicitis, learning the fundamentals of appendix ultrasound, recognizing normal and pathological ultrasound findings, and lastly, some pearls and pitfalls. So why appendix ultrasound? Appendicitis is one of the more common causes of abdominal pain, especially in the pediatric population. A timely diagnosis is crucial to prevent complications, and ultrasound provides a very valuable tool for early assessment. Ultrasound also has no radiation, which proves safer, especially in our pediatric population and our pregnant patients.
There's been plenty of studies linking radiation to leukemia. Just to put it in perspective, 50 milligray of radiation triples the person's risk of leukemia in the future, and 60 milligrays of radiation increases brain cancer in the future. And a CT abdomen is anywhere between 15 to 30 milligray of radiation.
So some of the indications for ultrasound appendix is right lower quadrant pain, fever and vomiting, and the pediatric appendicitis score of greater than 4. Here's the table of the pediatric appendicitis score. A score of greater than 4 makes it equivocal, and a greater than 6 makes it high risk. However, a absence of right lower quadrant pain with slight palpation as well as cough, percussion, or heel tap, along with an ANC less than 6,800, gives it a high negative predictive of not being appendicitis. There are a few transducers you could use in a pediatric appendicitis ultrasound. Here are a few of them listed on the screen. My favorite is the linear. It gives you higher resolution, however, you are limited by the depth. There's also the curvilinear, which can help you with retrocecal as well as with obese patients. And lastly, you have the intracavitary probe. This is especially useful with pregnant patients.
This is my preferred scanning technique. First, I ask the patient to point with one finger at the area of maximum tenderness. Then I choose my probe of choice, which is usually a linear probe. Given the high resolution, it is a great choice for an appendix ultrasound. However, after 5 to 6 centimeter in depth, the images can be less than ideal. Scanning in that area, we were able to see this hyperechoic structure right here with shadowing, most likely an appendicolith. Following that structure, make sure to get a long view, and here we quickly see that there is a long non-peristaltic structure, fluid filled in this case, right above the psoas. Make sure you put some color Doppler. It's not particularly hyperemic. However, we do see some free fluid. Again, this is the psoas muscle, which is another common area that the appendix lies above. And we have some fat stranding over here. Scan through, free fluid, again, seen around, either from a rupture or reactive. In the case the appendix is not seen immediately or around the region of maximum point tenderness, I like to move the probe in this direction slightly towards the head, followed by coming down towards the McBurney's points, down towards the legs, followed medially towards the suprapubic region, up towards the umbilicus, and back to the lateral side. These are the directions I tend to follow, shown by this arrows. Now, if the appendix is not seen at the area of point of maximal tenderness, I like to scan down towards the iliac vessel, which can be seen here. Scanning down, again, here is the colon, and here are the iliac vessels. And here you can see a structure sitting right above it. Again, finding out the blind ending pouch, non-peristalsis. Looking through, here you can notice, again with color flow, noticing the vessels and the structure coming right off the cecum. Right here, you can notice 3 distinct layers. Here's another view. Here you can see that the structure is only about 5 millimeters, which is not above the 6 millimeter cutoff. However, there is some early signs of appendicitis here, including some minimal fat stranding noticed here, um, as well as a little bit of edema on the outer wall. Later, a few hours later, when the scan was redone, we can see fat stranding is a little bit more prominent, and the short view, you can appreciate a thicker, more edematous appendix, again lying over the iliac fossa. Let's talk about other scanning techniques. Here, most of the time when appendix is not visualized is because it's either retrocecal or the cecum is full of gas. One way to circum this is to apply pressure from the posterior flank to displace the gas as well as to move the appendix from the retrocecal position. Another technique to use is a 3-position technique where you scan normally, and if you can't see the appendix, is to move the patient 45 to 90 degrees left side down and do a coronal scan like shown here in the second picture. Now, for children who don't really want to move, you can try to scan from the side, again in the coronal position with the probe marker facing up. And if this is still not visualized, you can attempt to bring them back to a supine position and rescan.
On the left, you can see a cartoon drawing of the appendix coming off the cecum. These are all the different positions it could be, and therefore finding the cecum and the terminal ileum tends to be the best way to try to find the positions of the appendix. On the right of the image, you can see an ultrasound appearance of the appendix, and in this case, it's above the iliac vessels. And you can also see psoas lying in the left, more deeper part of the ultrasound image. Again, here are some more still images of what a normal appendix would look like on ultrasound. As you can see, the appendix tend to lie above the psoas, and it's this blind ending tubular structure, less than 6 millimeters long. And the furthest right image is in the short axis, where you can see it's compressible. Here you can see the structures of the appendix with an ultrasound. So the appendix is a worm-like structure or a finger-like structure, basically a blind ending tube. It has multiple different layers. The outermost layer called serosa, followed by the muscularis propria, the submucosa, and then the mucosa. The appendix tend to be anywhere from 2 to 20 centimeters long, which is a huge range. However, the diameter tends to be less than 6 millimeters for a normal appendix. Here is another image of a normal appendix over the iliac vessels. As you can see here, the nice layering. There's no sign of any inflammation, and you can see the end of the tip. Again, here you can see a picture of a normal appendix right above the psoas muscle as well as the iliac, and the tip can be seen right at the end of it. Now let's shift gears and talk about pathological findings. Here are some of the images you can see. On the left upper corner, you can see a hyperemic appendix. We call it the ring of fire. And the lower two are, again, thicker appendix with some fat stranding around of it. Here you can note some free fluid below the appendix, and again, once again, inflamed appendix that is hyperemic with a lot of blood vessels around of it. Another example of a pathological appendix here, seen hyperemic, enlarged, and it's always good to put color flow in it. You can visualize the ring of fire around the pathological appendix. In this video clip, you can appreciate an appendicolith at the base of this appendix, which is enlarged, on the left lower portion of your screen. Here is another picture of a large appendix with purulent matter inside of it. Another good way to identify the appendix is through its origin. If you can see a structure coming out of the cecum in the right lower quadrant, as you can see here, it becomes pretty clear that this is the appendix. All right, let's talk about some other differential diagnosis of right lower quadrant pain. So here you can see some enlarged round structures, and when you put some flow in it, you will clearly notice that these are lymph nodes. Mesenteric lymphadenitis is the second most common cause of right lower quadrant pain in the pediatric population and should also be on the differential. Another differential should be considered is an ovarian pathology, especially in the female population. Here you can see using a curvilinear probe. Another less common differential we should consider is a Meckel's diverticulum. Here, the way to identify it on an ultrasound is the mucosa is a little bit more villous compared to one seen in appendicitis, and the length tends to be much shorter, between 2 to 3 centimeters. The accuracy of POCUS appendicitis has increased over the years, including several other studies showing the sensitivity is anywhere between 69 to 95%, but the specificity is what's important, which is incredibly high for a test easily done in the emergency room.
All right, let's talk about some of the pros and pitfalls. So when scanning for the appendix, make sure to be very patient, to scan slowly. It can be hard to discern the small bowel from the large bowel. Try to use some anatomical landmarks, such as the iliac vessels, the psoas muscle, um, and make sure you look for a finger-like structure or worm-like structure that isn't a blind-ending pouch and with no peristalsis. Now for the pitfalls. One of the largest pitfall is that a person with a larger body habitus, someone with a BMI of 30, or for a child in the 90th percentile, it can be very difficult to surpass the adipose tissue and go into greater depth to find the appendix, especially a normal appendix. It is easier to find an abnormal appendix as it will be large, there will be fluid around of it. However, sometimes a normal appendix can be very challenging, especially in those larger individuals.
Thank you very much.